everyone, I'm Danny Roddy of DannyRoddy.com, and today I'm talking with Georgi, aka Haydit of RepeatForum.com. Georgi is an independent health researcher and the owner of IdeaLabsDC.com, a small company producing high-quality boutique supplements with the focus of supporting a healthy metabolism. Today, Georgi and I will discuss hair loss and prostate cancer from a bioenergetic point of view, or the interaction between an organism and its environment, and how those changes influence cellular respiration. In addition to thanking Georgi for talking with me today, I'd like to thank my patrons for making this show and all the content I produce possible. If you would like to become a patron, go to patreon.com/DannyRoddy. As always, please do your own research and come to your own conclusions. And in the spirit of William Blake, the true method of knowledge is experiment. Without further ado, here's the show. Because I'm interested in hair loss, I've inadvertently had to read about prostate cancer because they're so interrelated. And the therapies, the mainstream therapies are very related. And I don't know, did you dig into this at all? What I could tell is that the whole idea that DHT is responsible for prostate issues and baldness it goes back to Merck and the creation of those drugs.
Yep, and actually Roy Vagelos, I think his name, he noticed a study from, it was some kind of female researcher who went to...
Imperato-McGinley. Julianne Imperato-McGinley, yeah.
Yeah, so she went to some kind of Caribbean island to study this unique population of people that don't express 5-alpha reductase.
Yeah.
And basically, they essentially grow up as hermaphrodites, but then they recover, I think, in around puberty. So the funny thing is they become super muscular because they don't have DHT, and DHT actually is not for muscle growth, unlike what many people believe. Testosterone is what, hypertrophies the muscles. But anyways, they grow into these super muscular males, but actually their prostates are atrophied because they don't have DHT.
And they didn't have acne either, and they didn't have baldness. And so I think after that discovery, don't quote me on this, but I'm pretty sure Imperato-McGinley started working with Merck, and they developed dutasteride and finasteride, obviously, which are 5-alpha reductase inhibitors.
Well, basically, the mainstream view, again, as usual, is at least partially genetic. There was a single study in Scandinavian countries, I forget it was in Norway or Finland, and they concluded that about 40% of prostate cancer cases are genetic. So the medical industry used that, and also the observation that androgens make the prostate grow, to essentially tie the condition, benign prostate hyperplasia and how it develops into cancer. I guess the mainstream view is that if something makes something grow, and there's some indication that growth in this organ may turn into cancer. So then, of course, supposing the thing that makes the organ grow is probably good. So this reminds me a lot of the the dogma about serotonin and dopamine, right? Mm-hmm. So back in the 60s, they observed that all the people, the hippies that took the dopamine drugs, they acted crazy, quote unquote, according to modern medicine, right? Uh-huh. So giving them something that opposes that must be good, right? So that's how the SSRIs and the whole thing about serotonin being a happy hormone came about. So it seems, this is my view, at least. I haven't talked to any doctors about it, whether they make a parallel between serotonin, but I'll talk about how serotonin plays a role in prostate cancer later. The bottom line is DHT is extremely trophic to the prostate cancer, to the prostate cells, and it makes the prostate grow, right? But there is no evidence that DHT directly contributes to either the development of prostate cancer or its progression. And in fact, there is tentative evidence to quite the opposite, which we're going to touch upon lately. But basically, I think the mainstream view is it is partially genetic, and then in the people where it's not genetic, local elevated levels, especially of the dihydrotestosterone, is what triggers and drives the progression of prostate cancer. So that's why the mainstream view is the treatment is the anti-DHT drugs, and besides, so finasteride is the type 2 and type 3. So there are 3 isoenzymes. 5-alpha reductase, they're basically present in different organs. And if you inhibit all 3, I guess you're achieving the perfect anti-androgen. Finasteride inhibits only 1 and 2. That's why it's not as bad as dutasteride. I would say dutasteride is the worst. And incidentally, it's used to convert males into females. So transsexual people that want to change their sex, that's what they take. So without stretching the official view too much, you can say that the current treatment for prostate cancer, aside from the surgery and the radiation, is basically turning males into females.
Well, at least in my experience of looking at the baldness research, it was testosterone causes baldness, prostate issues. And then when that couldn't really be verified, it seemed to switch into a more mysterious androgen receptor. And then that's still a point of contention. I think Gerald Pollack was the one saying how these theories go from really simple and they can't be verified to like ever-growing complexity. And then that complexity was a huge signal that the general theory was wrong.
Yeah, and also if you think about it, complexity essentially increases the point of entry. In other words, the barrier to entry, as business people like to speak, for anybody else with not enough resources to verify it or confirm it, right? So in other words, I think Pete talked about it in one of his articles when essentially the first test whether a cell has a membrane was done using such expensive technology that only one person within the U.S. government had. So it was basically, whatever this guy wanted to say, the response, okay. I mean, if you say so, there's nothing we can do. But initially, the theory really started as, people with prostate issues and baldness, and actually they tend to go together. The statement was, high circulating levels of androgens cause both conditions, right? Well, then several things happened. First of all, it was shown that people with the baldness and prostate cancer actually have lower than average levels of circulating androgens. And then the theory modified to say, it's the local levels of the androgens that really matters. Well, that was tested too. So they took biopsy samples from the scalp of people and also biopsy from the prostate. That also was actually the exact opposite. It was, basically the local levels, the tissue levels, which is really what matters. They were actually dramatically lower than normal, the control people. So then finally the version became, there are these, they call them mutated androgen receptors that are extremely sensitive to the androgens, and basically, any amount of androgens can trigger, these two specific conditions. So basically the view has morphed to the point that now they call advanced prostate cancer, they call it castration-resistant prostate cancer, because even after cutting out the prostate and even after, basically giving two types of drugs, the 5-alpha reductase enzyme inhibitors inhibit the synthesis of DHT. Even the best drugs only inhibit, let's say, 99%, which, pharma company thinks it's not good enough. So on top of that, they give people androgen receptor antagonists like flutamide and nilutamide. Both of them are used to convert males into males in transsexual therapy. So essentially, for all intents and purposes, when the prostates of these people are biopsied, there is no local DHT whatsoever, at least not detectable using modern lab equipment. And that's when they call it castration-resistant prostate cancer. And that is actually one that is most likely to kill you. Typically, even if you look on Wikipedia, you'll see that the 5-year survival rate for prostate cancer untouched is 99%. So you're probably better off like not touching your prostate cancer than touching off flu. You should just leave it alone if that statistics is accurate. You have better chance of surviving it than if you did anything dangerous. And I wanted to say that of course the anti-androgen therapies will shrink the prostate, but not in a good way. They atrophy it, right? So the prostate, in order for the prostate to function properly, it absolutely needs the androgens. Actually, it needs all three. It needs testosterone, dihydroepiandrosterone, DHEA, and DHT. Of course, DHT is the most important, but the other two are crucial as well. So the people who got this therapy to completely remove androgens and also block the effect of the remaining androgens, of course they shrank their prostate. It turned into a withering, atrophied little gland, but it harbored an extremely aggressive type of cancer that tended to kill the people that had it.
And the finasteride and dutasteride?
Dutasteride, yes.
Dutasteride. I've never said that out loud before. Those, you pointed to research saying they were carcinogenic, possibly carcinogenic, and then it's been known for so long, like on forums and the internet, and it just hasn't been taken seriously. People have said that Merck, there's a conspiracy that they knew finasteride was problematic and they were changing the side effects. And just now it seems like what you pointed to, the carcinogenic nature of those products, but also I think a paper called The Dark Side of 5-alpha reductase inhibitors, like it seems the word is out that these drugs are not only not really effective, but extremely dangerous.
Yeah, last year actually, incidentally, there was a group formed officially as I think it was a lobbying body or a nonprofit in Washington, D.C., and I live only a few blocks away from where the headquarters is. It's called the Advocacy for Post-Finasteride Syndrome.
Yeah, I think I'm subscribed to their newsletter.
Yeah, and basically now they're lobbying, they're trying to collect money because everything in this country they want to do requires money, to lobby Congress to basically force the FDA to, if not withdraw the drug from the market at least include a black box warning that says this thing will destroy your brain and your libido for life. I don't think it's for life, but it's really dangerous. So I want to list several risks of what these 5-alpha reductase inhibitors can do. First of all, they're known to dramatically increase the risk of first of all, they don't improve survival once you have prostate cancer. Probably the most important thing. Second, they don't reduce the progression of BPH into prostate cancer. So these two reasons alone should tell you that you probably don't need, at the very least, you don't need to take these 5-AR inhibitors if you have prostate cancer or BPH. Third, they increase the risk of breast cancer in males, right? And it is known that also they increase gynecomastia in males. And it's known that these two conditions, both in males and women, are mediated by estrogen and prolactin. So it is fairly common knowledge among endocrinologists that in males at least, and I don't see why not in females if they ever take these drugs, that in males at least, these two drugs, basically, they're estrogenic. So we know the role of estrogen in breast cancer. And also, all estrogenic substances tend to burden the liver and potentially even develop cancer in the liver. So I posted several studies on the forum, and they're fairly recent, showing that specifically finasteride caused several cases of liver cancer. And when the patients were given DHT or DHEA, the cancer disappeared. And basically, if you take these drugs, you're essentially chemically castrating yourself. So if you take high doses, you'll turn into a woman literally, and if you don't, you have the symptoms of being an anti-male, if there is such a thing.
If there's one personal anecdote, like a criticism of the movement of people that have been harmed by Propecia or finasteride, it seems like they're saying, this is a lifelong thing and I'm screwed for life and I can't really do anything. When in just my limited experience, when people send me labs that have that orientation, it always seems like they're hypometabolic or they have really high levels of prolactin or something. There's something to identify to try to fix to feel better.
Yeah, I wouldn't label any problem unfixable. I have seen no principle in nature that would make something unfixable. I don't know if it kind of like on a tangential topic, but one of the bastions of modern pathological science is the second law of thermodynamics, that essentially everything breaks down. There's nothing you can do about it, and it's irreversible, including the universe, which they call the heat death of the universe. Well, it was recently potentially falsified. In other words, if the universe is an open system, and as Ray says, there are no closed systems anywhere unless they're artificially created. There's no closed systems. Nothing is irreversible in principle. There's quite a few people that send me emails or post on the forum, and quite a few of them have improved. Basically, one of the really bad things mentally that these 5-alpha reductase inhibitors do is because, first of all, they inhibit the synthesis of pregnenolone. And we know that pregnenolone is extremely important for brain, for mental health. And of course, they inhibit the synthesis of DHT. DHT is also a neurosteroid. DHT administration has dramatic antidepressant effects, very similar to ketamine. Ketamine is currently in clinical trials to reverse the depression that is not amenable to even electroshock ECT, electroconvulsive therapy. So DHT and ketamine both reverse it within a week. So also, because now there's evidence that the 5-alpha reductase inhibitors, they don't inhibit only 5-AR, but they also inhibit the 3-beta hydroxysteroid dehydrogenase and 17-alpha hydroxysteroid dehydrogenase. So in other words, they inhibit the entire cascade, and also they inhibit the synthesis of pregnenolone from cholesterol. So really nasty stuff for your steroids altogether. If they inhibit all of these good steroids, basically what you end up with is the end path, which is cortisol and estrogen, as Pete and I think I have mentioned many times.
So if it's not the result of the androgens, how would something like baldness, prostate cancer, and we haven't really touched on it, but we should, like low libido, how would those problems result in our modern day world?
Well, whenever you have stress, you'll suppress metabolism. Basically, if thyroid hormone there's not enough thyroid hormone, or your cells are not reacting properly to it, they cannot uptake it for whatever reason. Usually it's crowding by PUFA. So in other words, if you eat the modern day diet and you're exposed to stress, you'll have high circulating levels of free fatty acids. Most of them will be polyunsaturated. They will block uptake of thyroid into the cell, and you'll have metabolic problems. If you have metabolic problems, if thyroid hormone is not functioning properly, the clearance of cortisol and estrogen dramatically decreases, but their synthesis increases. So you will tend to have elevated levels, at least in tissues, which is where it matters, of both cortisol and estrogen. Basically, it is known that the incidence of both the baldness and the prostate cancer and the BPH, it increases with aging, right? So if the androgens were responsible for it, you would expect 20-year-old males to be running around completely bald and with the prostate the size of a Vidalia onion. It doesn't happen. It just doesn't. Biopsies have been done on these people and has been shown that they have high levels of the androgens both in the prostate and in the scalp. So what happens basically is once you're hypometabolic, the three, I call them the three of poisons, actually four really, cortisol, estrogen, prolactin, and serotonin are all likely to be elevated, if not centrally, at least in peripheral tissues, which is where it matters. And in hypometabolic conditions, often the first things that start to malfunction are things that are considered non-crucial by the body, which is the reproductive system and probably hair. Skin is another thing that atrophies. People with baldness are prone to premature skin atrophy. Look at people on the street that have bald. You'll see that if they are wearing short sleeve shirts and shorts, you'll see that the skin is flabby. It's sagging, and it's not surprising. Androgens have been used back in the 50s to reverse skin aging in both men and women. And by the way, in women, the impact was a lot more dramatic. So in our modern life, you'll have stress, you'll probably have hypothyroidism, you'll have elevated levels of the anti-metabolic biomarkers, the disease, the sickness, the aging field, mediated by cortisol, estrogen, and prolactin. So basically, the first things that will go are the ones that your body thinks you don't need, and that's where it manifests itself.
At least in the hair follicle, I can't really speak. I haven't studied the specifics of the prostate, but the energy requirements of hair growth are like insane, and it can't use fatty acids like it can glucose. I think that's a sign of proliferative tissues like the skin. They have inefficient metabolisms that's mostly glycolytic. Subbing with fat just doesn't work. It doesn't fuel their needs.
And by the way, prostate has the same metabolism. It's also very inefficient. It accumulates zinc, and the way it produces energy is really inefficient. Anything that inhibits that inefficient synthesis of energy, basically, it's likely to make the prostate to start growing, which, as we know, the growth and proliferation is the primary goal of every cell in your body. We are mechanisms for restricting that growth. And if you interfere with that, if not cancer, then some other pathological condition will probably develop.
I was going to mention the biomarkers you said, like just because the physician says the tests are normal, I think it's good to go the extra mile and test the temperature and the pulse rate and question the assumptions of the physician on whether the tests are truly normal, maybe get a second opinion on things like you were talking about, like the prolactin level and the TSH.
So let's talk a little bit about the biomarkers. There are actually some blood biomarkers that are very good and immediately confirm Ray's view. One, as of now, the two biomarkers that are used to diagnose and track the prognosis of prostate cancer, it's PSA, and I don't know if many people know about that, but it's also the hormone estrone, and especially estrone sulfate. This is basically one of the estrogen metabolites. So you basically have estrone, estradiol, and estriol. And of these, estradiol is considered the most potent, but it's really not that's not the case. There's no such thing as a less and more potent estrogen. They're equally bad for your cells, both metabolically and in terms of removing the restrictions on growth. So basically, mainstream medicine says that for this, ostensibly androgenic-driven conditions really, because it's both baldness and prostate cancer. So it's actually estrogen, a type of estrogen that is the biomarker for both diagnosing and the prognosis of the disease, right? So right then and there, something should tell you that when if your doctor asks to test or even do a biopsy to confirm local levels, I think before you venture into that, because there are a lot of, I don't think most men understand, but they probably can visualize how unpleasant it is to get a 20-inch needle stuck into your prostate. By the way, without any anesthesia, because there's really no way to deliver anesthesia there, unless you want to get epidural, which most doctors frown upon because it has its own risks. So in other words, before doing that, check your estrogen levels. And because estrogen levels are not very reliable as blood biomarkers, actually estrone and estrone sulfate in the blood are deemed to be reliable. So you can do those. But of course, prolactin. I think prolactin is a much better biomarker because it is a very good indication of both how active the estrogen is inside cells, how actively it is synthesized, and also the total serotonin reserves of the body. So prolactin, I would say, is a very good biomarker probably for most people, whether they have baldness and prostate cancer or not. It's just a very good indication to see how well your metabolism is doing. And by the way, serotonin was also found to increase the proliferation, both the incidence and the proliferation of prostate cancer. So as you can see, even modern medicine is wising up to the fact that estrogen is most likely the driving factor. Prolactin is another good one, and it's not only it's not only associated with prostate cancer and baldness. Actually, there are several studies showing that it directly causes the development of cancer in the prostate. So things that people can do is dietary. I think one of the most powerful anti-estrogens in our diet is mushrooms. And Ray recently wrote about it in his newsletter. Mushrooms have two components that basically one of them inhibits aromatase, so it's aromatase inhibitor, and the other one actually blocks the estrogen receptor. And of course, we know that Ray doesn't believe in receptors, and actually neither do I. But basically, the mushrooms act like vitamin E almost, because vitamin also inhibits aromatase and also acts like an estrogen receptor antagonist. So eating diet of good mushrooms, of good well-cooked mushrooms, of course, avoiding PUFA. There was a study recently that after all of these, all the big trials with, especially with the omega-3s, the one thing that came out that was definitive was that supplementation, which specifically with DHEA, but also the combination DHA and EPA, supplementation with DHA dramatically increased both the risk of getting a very aggressive type of prostate cancer. I think on the scale of 9 to 10, it was 9 and 9.5, and also dying from it. So it was already resistant to all of the therapies that modern medicine is able to throw it in. I would say keeping good metabolic function, of course, is critical, because detoxifying the estrogen depends on the levels and the activity of thyroid hormone and also your liver function. Other things you can do to oppose estrogen, of course, aspirin, vitamin E, vitamin K, caffeine, all of these oppose estrogen and inhibit its synthesis. Progesterone, the mushrooms were already mentioned. Nettle root is another good aromatase inhibitor. And actually, nettle root extract is approved as an actual medicine in Germany for treating BPH. And nettle root has no known anti-androgenic activity. So if this thing treats BPH and its sole mechanism of action is anti-estrogenic, and I think you have 80 million people in the world voted that estrogen causes basically BPH in Germany. So that's that. I think other things that could be beneficial, raising the levels of estrogen, so at least the synthesis of androgens. Thyroid hormone is very crucial for that. I posted a study which showed that in cases of mild hyperthyroidism or just improved metabolic activity, increased levels of thyroid hormone, what happens to the steroids? So basically, hypermetabolic people have dramatically increased turnover of cortisol. They have quadrupled the rate of synthesis of androgens, and they also have half of the synthesis of estrogen of normal thyroid people. So that right there tells you that good metabolic function is crucial for both the prevention and potentially treatment of these two conditions. But if you don't have access to thyroid hormone, or if you're feeling hypometabolic, you don't know, and your doctor doesn't want to treat it, other things you can do is you can take small doses of DHEA. In single doses of under 5 milligrams have been shown to convert preferentially into DHT. If you apply it topically, it will do even more so. It's about 10 times more androgenic if you apply it to the skin than if you ingest it. If you have access to DHT and testosterone, that will also be a good thing to do, but it requires a prescription. And incidentally, I wanted to mention there is a recent study, which I think, Danny, I sent you the link for. There were 8 cases of terminal prostate cancer. Nothing worked on these people, right? And of course, in a wave of brilliance, but even though this is not a surprise to anybody who listens to this show, the last thing they tried is inject testosterone directly into the prostates of these men. And guess what happened? All of them had metastasis disappear. And as far as I know, none of them is dead as of right now. That was 3 years ago. They had terminal prostate cancer.
One of my favorite things, I think, in Ray's newsletter, where he talks about prostate cancer, is when the physicians were asked what they would do if they had prostate cancer, and most of them just said they'd do nothing.
Well, yeah. I mean, Wikipedia, which is the consensus of the people here, especially the medical establishment, as Ray says, it says the 5-year survival rate is 99%. Right? So the chance of you dying from prostate cancer is lower than probably, I don't want to say that, but it's comparable to probably getting hit by a car on the street. And most people take that risk every day. So other things that people can do other than the androgens is oppose prolactin, and several reasons for that. Basically, prolactin, like I said, is not just a metabolic inhibitor. It's shown to be directly a positive factor in the development and progression of prostate cancer. So basically, anti-prolactin drugs like bromocriptine, lisuride, cabergoline, methisargide will probably be helpful. And on the non-pharmacological field of things, vitamin B6, especially its activated version, pyridoxal 5-phosphate, small doses, 5 to 10 milligrams a day, have been shown to suppress prolactin and consequently increase dopamine. And why is it important to increase dopamine? Dopamine also inhibits the synthesis of serotonin. And serotonin was recently found to directly stimulate the growth of prostate cancer, to convert the more or less benign condition, because that's what it's called, BPH, benign prostate hyperplasia, to accelerate the conversion of BPH into high-grade prostate cancer. And the study was done as an epidemiological study. They noticed that people on SSRI drugs have a dramatically higher chance of getting that type of cancer. So then they did an actual direct study, and it was confirmed. And it looks like if you believe in receptors, it's the serotonin receptors 1 and 2 that are involved. So taking antagonists to those receptors are good old friend cyproheptadine and meancerin, ketanserin, mirtazapine. All of the serines is probably going to be beneficial for conditions of the prostate. And I think the same things apply for hair loss as well, because as we just said, the two conditions are so tightly interrelated. There's a good likelihood that the same mechanisms are at play.
And vitamin A is just important for the protective steroid synthesis. The one vitamin that is talked about in baldness research is surprisingly vitamin A, and this goes back like decades.
Guess what vitamin A does? It's an estrogen receptor antagonist. There are studies. I think there are studies with high dose vitamin A in late stage breast cancer right now going on in Italy, and the results are fairly good. When I say advanced, means these people basically have exhausted all other options, have probably been damaged by multiple rounds of radiation and chemotherapy, and even then, vitamin A seems to be able to delay the inevitable.
One of the things, at least in baldness research, which was really ignored, at least on the baldness forums, like the current state of them, how nasty and negative they are, is nobody is willing to look at like women and see how they overcome so-called male pattern baldness. But there's lots of instances where a female will be experiencing male pattern baldness and will get pregnant and then will overcome the problem. And of course, pregnancy is a condition where the woman is producing tons of progesterone.
Yeah, it's progesterone-driven condition. That's right. And by the way, these women actually, when they're pregnant, they have low levels of androgen. Once again, it's really not the androgens that are here.
What do you think about dutasteride and finasteride being similar to progesterone? Somebody sent me an email a long time ago saying that their chemical structure was virtually identical. I couldn't tell. It looked really similar to me, but I couldn't tell. And then I've read reports of women with so-called male pattern baldness who didn't obviously have high levels of androgens overcame their baldness by taking finasteride, which doesn't really make any sense given the explained mechanism of finasteride. It's an anti-androgen. And so if the pill was a progesterone-like substance, it might make sense that just increasing levels of progesterone might have some effect on estrogen and prolactin and cortisol and serotonin and help restore hair growth.
Yeah, I mean, looking at the structure, I'm seeing it right now. It is very similar. I think it's an isomer of testosterone, by the way. That's how it was developed. Since all steroids are very similar structurally, of course you can say that finasteride is chemically similar to progesterone. It does have some progesterone-like activities. As we know, in large doses, progesterone is anti-androgenic. But the thing is, in the studies that I've seen, finasteride does not bind the progesterone receptor, which is the golden standard right now for having that, for having progesteronic activity. Also, if it was progesteronic, I would expect finasteride to inhibit estrogen synthesis and also oppose estrogen, which it doesn't. It's actually the exact opposite. It's estrogenic. It may be one of the abominations called the SERMs, selective estrogen receptor modulator, or maybe PERMs, a progesterone receptor selective modulator. It is possible. I mean, there's some chemicals extracted from I think from the Vitexin plant.
Vitex.
Yeah, Vitex, which is it's called chasteberry, and they are actually a natural not derivative, but they are essentially natural variations of progesterone, and it does look similar to them. So I wouldn't exclude the potential that finasteride acts like a selective synthetic progesterone in some tissues, but just like the other selective drugs, it is very estrogenic, especially in the liver.
In your research, did you read about cyproterone acetate at all? I think that drug is actually more similar to progesterone, and that was used to treat baldness and a host of other problems, including like hypersexuality, like they'd give it to people that did sex crimes and stuff. But that, as far as I can tell, that was used pre-Imperato-McGinley's 1970s discovery, and that was used to treat baldness and I think prostate problems too, and it was given to women for hair loss. And a lot of the times the paper will describe it as an estrogen, but I think it's really clear if you dig into it, it has progesterone-like activity.
Cyproterone is actually, it is a progesterone. progestin officially. It is a synthetic progestin, and it is known to be anti-androgenic and anti-gonadotropin. So, which means it will inhibit the synthesis of the other steroids. So, if finasteride and dutasteride are similar to that, then they are. I guess they can be considered synthetic progestins. So, but again, I think it's like if it's possible to be selectively progesteronic, just like the estrogen thing, because they've been shown to not be progesteronic in other tissues. I do agree that it's likely one of the mechanisms of action, but it's probably like the SSRIs. It's the law of unintended consequences. Just like the SSRI drugs turn out to increase pregnenolone synthesis. And actually, some of them turn out to be serotonin receptor antagonists. I think I sent you a study on Prozac actually being a selective, once again, that word, selective 5-HT2 receptor antagonist, similar to cyproheptadine. But of course, it's selective, it's partial, because since it inhibits the reuptake of serotonin, it will increase its circulating level. So you're getting, whatever benefit you're getting, it's from an unforeseen side effect of the development of the drug. Probably the same thing with finasteride and dutasteride. Even though I'm not aware of many studies with dutasteride for hair loss, I think it's only finasteride that is used. Dutasteride is mostly for BPH. So if these drugs are very similar, and dutasteride actually inhibits all three isoenzymes of 5-alpha reductase, so in theory it should be even more effective than finasteride for hair loss, but it isn't. So finasteride is the preferred drug of choice.
I think it's been known to anybody that researches pattern baldness, but it's not just baldness. We already talked about prostate cancer, but also cardiovascular disease is connected to baldness, so-called metabolic syndrome, hypertension, etc. So it's pretty obvious that there's like a systemic problem here, and then it's debatable about what's causing that systemic problem, I guess.
I think there's enough evidence to back up Ray's claim that in the absence of definitive evidence to the opposite, all disease should be treated as systemic. I don't know of what condition there could be other than like a local wound or laceration that would not trigger a systemic effect, even that well. Like if you hurt yourself, the levels of serotonin both in your brain and peripherally will dramatically increase. Even if it's just a small cut or somebody punctured you with a needle. So even that is wide systemic effect. So I don't know of basically why isn't this condition looked at? I guess it's an outgrowth of the genetic theory is very localized. If you look, it's one gene, probably in one tissue, and there's only one protein that really interacts with it. So it seems it's a very logical, deductive outgrowth of genetics. I think there's solid evidence to the opposite, because these conditions are so interrelated with so many other conditions. And everybody admits to that, but then yet everybody insists of treating them as localized conditions. Again, so the first things that would go and the first things that will be sacrificed by your organism if energy production is somehow reduced are things that are deemed non-essential. And it has been shown that in virtually all stress conditions, the first things that go are the gonadal system. There were actually studies done by the Soviet Union, which were suppressed for over 50 years, that were done with the people that they sent to the gulags, which were the forced labor camps in Siberia. The majority of the people that were sent there lost their hair within a few months. Of course, we don't know if that's the same condition as androgenic alopecia, but it is shown that stress will essentially will inhibit your reproductive system, and it will make you lose your hair. So at the very least, I think the connection should be reevaluated.
There's a few studies I can think of, but one specifically that younger males with androgenic alopecia, so-called, had higher levels of DHEA. And you'd be a better person to ask about this than me, but I'm pretty sure DHEA goes up during initial periods of like intense stress and then bottoms out later. Is that accurate?
That is, DHEA, one of its primary, even according to official medicine, one of its primary, because there's no receptor to which it binds, at least, because the modern medicine likes to talk about receptors. There's no specific DHEA receptor. However, it does bind to the androgen receptor. It is considered weaker androgen than both testosterone and DHT. And it's also considered the main endogenous anti-glucocorticoid agent. In other words, it opposes the action of cortisol. So whenever you're under some kind of stress, likely the things that will rise, other than the stress hormones, are hormones, steroids, and substances that your body reactively produces to restrain the stress response. But this only happens if your metabolism is good. If it's not, if you have any kind of condition or metabolism is not working well, the only thing that will rise inevitably is the hormones of stress. They always rise, but you will not be able to produce some of the opposing things like progesterone and DHEA. And by the way, if DHEA levels rise in these people, it means that something is inhibiting either increasing the synthesis of it or decreasing the conversion of it into downstream steroids, one of which is DHT. it's basically, I wouldn't be surprised if these people had some kind of a 5-alpha reductase temporary deficiency because they have high DHEA and low DHT. Did anybody look at the levels of DHT in those people? If their levels are low and DHEA is high, then I think this is essentially kills the whole hypothesis of androgen-driven baldness.
One of the last things I wanted to talk about was, I think Ray said that a higher ratio of free testosterone to bound testosterone in the blood explained the stress estrogen condition and its intersection with the liver and sex hormone binding globulin. Did you want to talk about that at all?
I think there's a big misconception currently going on that it's only the free hormones that are active. That's not true. For example, after menopause, right? Women, even according to official medicine, they have low levels of both estrogen and progesterone, and they have low levels of total and free estrogen. However, in the tissues, in the breast where the cancer develops, the levels are extremely high of estrogen, and there's estrogen receptor positive breast cancer. Nobody denies that. But the way these hormones get into the cell is by binding to these hormones, either albumin or SHBG. So with higher levels of free hormones indicate that you're not producing one of these two proteins, either SHBG or albumin. And I believe both of them are produced by the liver. So if you have low levels of these, at least SHBG, low levels of SHBG have been shown to be directly implicated in the development of diabetes. And this shows you again why steroids are important for, basically they have a bigger role than simply for determining the sexual characteristics. A lot of them have metabolic effects as well. So people with high levels of free hormones probably have low levels of the carrying proteins such as SHBG and albumin. And these two, having low levels of this is really a very good indicator of poor health. By the way, low levels of albumin are the best predictor of premature death, and it was recently confirmed.
The last thing I wanted to talk about, and let me know if there's anything else we didn't cover, but we're talking about prolactin intermittently through this episode, and calcium is a major inhibitor of prolactin secretion. Did you want to talk about how that works? Like, prolactin is released from the pituitary, and one of its main functions, along with parathyroid hormone, is to break down the bone to provide calcium in the blood.
So there are a couple of reasons for elevated prolactin. One is primary prolactinemia, hyperprolactinemia. It's caused by a tumor in the pituitary gland, and this is one of the tumors where basically if you give a drug that opposes that inhibits the synthesis of the hormone, the tumor regresses and in many people completely disappears. Secondary hyperprolactinemia, I think, is a lot more interesting because it is very common in all of these conditions that we now know to be metabolic. For example, people with liver disease have elevated levels of prolactin. People with kidney disease have elevated levels of prolactin. Hypothyroidism is actually one of the biggest triggers of hyperprolactinemia. And also not getting adequate intake of calcium, just as you said. Your body needs a constant supply of calcium in order for the Krebs cycle to work. Without sufficient supply of calcium, metabolism shuts down. So basically, your body will do what it can to get the calcium it needs. And if you don't ingest it in the diet, and if you don't have sufficient levels of vitamin D, so you may ingest calcium, but you may not absorb it. So if you don't ingest calcium, or you have low levels of vitamin D, the body will get the calcium it needs from your bones, just like it does in women that have children. Prolactin is elevated postpartum because if the woman is breastfeeding, or whether she does it or not, doesn't matter, but she has milk for a couple of months after postpartum, and prolactin is highly elevated during that time. Whenever your body needs calcium, it will get it either externally or from you by dissolving your bones.
So besides nutrition, what other things, like, I know I'm not super interested in topicals myself, but over the last few years I have been interested because things like aspirin and caffeine are so cheap, and I know you've written a lot about that on the forum, Georgi. Did you want to talk about that at all?
Yeah, and I think this is one of the best indicators why hair loss is so tightly correlated and tightly coupled with your metabolism. Basically, it has been shown that the topical application of the thyroid hormone T3 results in restored hair growth. And I think it was animal study initially, but it was recently confirmed in a human study in Germany. And other substances that have been shown applied topically to be helpful include aspirin, caffeine, niacinamide, DHEA, which is an androgen, by the way, DHT, and vitamin B6, and I believe also biotin. All of these things, by the way, also antihistamines and anti-serotonin drugs as well. So all of these things happen to have a very potent pro-metabolic effect, and some of these are actually direct surrogates for thyroid hormone. Aspirin, caffeine, and vitamin B1 are actually substitute very well for thyroid hormone. I think that shows very well the bioenergetic connection because all of these things act in a very coordinated pro-metabolic way and oppose estrogen, cortisol, and prolactin and serotonin, which are implicated in both prostate cancer and baldness.
And maybe I should qualify that statement. One of the reasons I'm not super stoked on the topicals is I think it ignores the systemicness of the problem a lot of the time. I'm sure you experience it too, but a lot of people are looking for topicals versus changing the way they live for the problem they're experiencing.
Absolutely. Things should be looked at systemically. Fortunately, with the topical application of these things, they do get absorbed and they will have a systemic effect as well.
Awesome, man. Where can we find more of your work on the internet this week, Georgi?
I post very often on the Rapid Forum. Website is www.rapidforum.com, one word. My username there is Haidut, Haidut. You can also send me an email. My email is haidut@gmail.com. And you can visit, if you want, my company's website. It's www.idealabsdc.com.
Georgi, you're awesome. Thanks, man.
Thanks a lot. Thanks for having me.
That's going to conclude this week's episode. I'd like to thank Georgi again for talking with me today, along with my patrons and their support of the show and all the content I produce. Thanks again for the awesome listenership. Please hit that like button if you're on YouTube and leave constructive criticisms or comments in the comment section also if you're on YouTube. Next week, we're going to talk about PCOS or polycystic ovarian syndrome, along with breast cancer, so you can look forward to that. So again, thanks for listening, and I'll talk to you guys soon.